The community health worker, within the World Health Organization, it's a classification of health worker that's usually from the community. And the foundation of that education is, health equity. It has been forever. Our college has had one for a long time. And when community paramedic came up, I remember an article written by John Todaro I think it was called EMS 3.0. He wrote an article about how community paramedic should really be using the CHW. That's the CHW curriculum, because it is motivational interviewing, equity, all of that is.
You're listening to Cold Press Conversations with Dr. Jewel White Williams, a lover of numbers, lists, and a good glass of cold press juice, who is sharing episodes each week to help you explore the back end of healthcare and health sciences, where a lot of that grit is done. We'll dive into topics covering research, education, and clinical practices, as well as guest shows with other leaders in the field. Pull up a seat and let's dive into these amazing and game-changing conversations. Hello, I am Dr. J, or Dr. Jewel White Williams. Dr. Jewel, I am your host of Cold Press Conversations, and I just had an interview with Dr. Megan Corry. Now, to understand who she is a dynamic leader at the forefront of revolutionizing paramedic education and pre-hospital care. She has a unique blend of field experience as an emergency medical technician paramedic and academic expertise. She serves as a program director and full-time faculty for the esteemed City College of San Francisco paramedic program. She is dedicated to excellence and extends beyond the classroom. She actively contributes to shaping the future of EMS through her roles on prestigious advisory boards. Now, she's a trusted member of the Board of Advisors for the UCLA Pre-Hospital Care Research Forum. Dr. Corry plays a pivotal role in guiding groundbreaking research initiatives aimed at enhancing pre-hospital assessment and treatment protocols. Additionally, her commitment to ensuring the highest standards of education is demonstrated through her service as a site visitor for the Committee on Accreditation of Educational Programs for the EMS Professions, where she actively evaluates and influences the accreditation process for EMS programs nationwide. Dr. Corry's passion for advancing paramedic education is further reflected in her research pursuits, where she focuses on translational studies aimed at refining the initial training of paramedics to improve patient outcomes. She has this keen eye for innovation and a relentless drive to challenge conventional norms, and she embodies a vision for continuous evolution in research, education, and clinical practice within the field of emergency medical services. It is my esteemed pleasure to invite Dr. Megan Corry to this platform, and may you enjoy this amazing interview.
Let's think about this. Let's think about the evidence. Let's think about the data that we have to support it, and the real impact on people. And
Oh, I love that. I like what you just said, though. The impact on the people. That's one of the reasons why I love what I do with research. I think it's just innate in me, because I want to see exactly how does it impact the individual collectively. And then you have to dig even deeper after you find out what it does. And I think that's what formulates the classes or the talks or the forums or the additional research that you have out there. And I think that's what I like.
I love that, Dr. Jewel, because I love that all you need is to be curious, and every human being is curious. So therefore, every human being can be a researcher. We've made it into this academic thing sometimes that you have to have this or that. But the academic structure is really just something to help you move along and finish something and keep going. It's really more of like riding a train rather than trying to walk through a forest. It's a little bit more of a assistance in research than it is anything, but we're all curious. But I like that you're saying it's very personal and it's soul searching. It really is soul searching. It's more than just, I need this p-value and that number and this paper. And, every good dissertation is a done dissertation and that kind of thing. Although I understand that. I understand it, but it really isn't done. Yeah, it is. It is. It's soul searching, and it comes back up, and there's something to it that's deeper.
Yeah, I'm not a paramedic yet. I would like to be, but I work with the community paramedic program here.
Don't you think there should be community EMTs, though?
There are community EMTs.
Well, CHWs and EMTs should really kind of combine a little bit. Community health workers and EMTs.
It's very similar. So I went through the program from the Paramedic Network and Albany.
Oh, Yeah, I'm not familiar with that.
So Al Benny is the instructor
Oh, I
for,
thought you said Albany, like the place.
no,
It's
Al Benny.
Albany.
Yeah,
Okay.
he's a paramedic. I know, doesn't
Yeah.
it say Albany? Um,
Now, if he was from Albany, that would be even
right, that
better.
would be cool,
Al
wouldn't
Benny
it?
from Albany.
So I went through something like a community EMT program. It's the same
Hmm.
program that community paramedics go through, except for they've put it down into an EMT value where you learn everything that you could think of under the sun. You get the books and all. I had both books for community paramedic, had to go through the entire course. It is a self-paced course, but of course, Jewel goes beyond. And I was really,
Hmm.
really reading it because I wanted to understand it. And I really liked it. And they don't call it community EMT. Minnesota actually has some community EMTs.
That's great.
So what I do, even though I'm not officially a community EMT, I am a community EMT. They call it a patient technician. I think that's the way they call
Hmm.
it. They use different terms, of course. So I have my certificate stating that I went through the program as an EMT
Hmm.
through the community paramedic program. So I've learned a great deal from that process. And I
Yeah,
love it because it allows me to see it from so many angles. It encouraged me to get my geriatric certification so that I can have the geriatric side. So I have
that's
my,
wonderful.
yeah, so I got that. And that tells you a heck of a lot. It's hard to find the course, but through their program, I think it's called Hennepin Community College, and you can get it through them.
That's great.
You can also get cert points when you go to the weekly meetings. They have it once a week, normally on Mondays. And I'm working every Monday, so I haven't been able to get the course, but you can actually get your CEUs through there and it can go
Hmm.
towards your EMT for your national cert.
Wow.
So it's a great program. So I really do like it, but it's not recognized anywhere else. And it's not called community, it's called patient care technician or
Yep.
patient
Yeah.
technician thingamajiggy. But it's pretty neat. It expands. So what I was getting at is that once you go through the program, you could write a very quick paper about your community needs assessment. Well, you know, Jewel doesn't just take it to an inch. I took it further. I decided to do a scope and review
Hmm.
based off of the articles and looking at my community health needs assessment in our area, which focuses on 7 counties.
Yeah.
And let me tell you, I learned so much in that process.
Yeah.
Because I have never written a scope and review. I had to read certain things and I got my editor to go through it and clean it up. I was really, really excited. That's what I did last year as a paper, just to kind of keep my writing skills up. But it allowed me to learn even more about the community that which I serve. It was intriguing. I was like,
Yeah.
wow, this is
Yeah.
awesome. I didn't know we didn't have this. I didn't know we didn't have that.
The community health worker, in the World Health Organization, it's a classification of health worker that's usually from the community. And the foundation of that education is, health equity. It has been forever. Our college has had one for a long time. And when community paramedic came up, I remember an article written by John Todaro I think it was called EMS 3.0. He wrote an article about how community paramedic should really be using the CHW. That's the CHW curriculum, because it is motivational interviewing, equity, all
Yes.
of that is. And he was right. I contacted him and said, I love this because that's what I've been saying to our local. This is like in 2016 or 17. Why don't you just have the paramedics take our CHW program? Because then they're taught by public health experts. They're taught by, health scientists. They're not taught by a paramedic who took a class. It's not going to be one of those, we teach our own based upon the little bit of knowledge we have. You're being taught by the people who actually work in public health. And there was a lot of pushback on it. We like to do our own because then we can do it on our battalion-based training and it's 150 hours and we have to reschedule them. We don't want it to be a whole year or semester, whatever. So I'm trying to get them to recognize at least the CHW program as the foundational curriculum. One of my graduates went through the CHW program to help me with that. And he came up with this great idea. He said, the people in the CHW program are amazing. Number one, they're much more diverse than we see in EMS. They're truly from the community. Maybe they want to treat addiction. They had a background in addiction. Maybe they want to, get involved in geriatrics or in, homelessness. They were once homeless, something like that. And then he said, I think we kind of have it backwards. I think we should be recruiting EMTs from that pool. I said, that's brilliant. So instead of trying to take the mindset of the paramedic who's already, indoctrinated in our education programs with this mindset of who deserves care, which I hate, but we know where it comes from. It comes from the education program. It doesn't come from their backgrounds necessarily. Yeah, we learn that, in America, watching TV and everything else, but they're also learning it in education. in their books, the hidden curriculum, as Jamie Kennel always refers to it. And
Yes,
so when they get out in the field, the horse is out of the barn already. And then we take them and we say, okay, now we're going to train you in motivational interviewing and health equity and all of these other things. And they're like, what? But wait a minute, I have this, paternalistic medicine mindset that you need to listen to what I'm saying. These are the best practices. You have to take your medication. And that's not what motivational interviewing is about. That's not what the CHW work is about. And if that's the foundation of the community paramedic, then trying to get people to stop thinking that way and thinking in terms of what the patient wants and needs. It's interesting because we've seen a lot of clashes in San Francisco. We have a lot of multi-service center workers, CHWs, out there on the street working with their clients. They call them clients. And then we've got this force of community paramedics on their special units. And sometimes when they come together, there's a bit of a clash or a learning curve because the community paramedic, not so much anymore. I think they're getting better, but more along the line of, does this person need follow up with, traditional medicine kind of thing? And the community health worker might speak the language too that the patient speaks or that the client speaks. They don't go to the hospital. They go to this traditional medical clinic in Chinatown, or they've said to me they just want a banana. So I'm just going to run over to the market and I'm going to buy the guy a banana and I'm going to bring it over and then we're going to talk. And so the community paramedic, that's like, what? A banana? I've had that story. I've had CHWs tell me, yeah, I've been sitting with this guy and he just kept saying over and over again, I just want a banana. I just want someone to get me a banana. And the community paramedic was like, look, we need you to talk to, it was like the way they learned how to interview people through interrogation. And the CHW was like, hold on a second here, runs over, grabs a banana, brings it over. Here you go. Thank you. Then he starts to talk to them about his needs, his food insecurity and housing insecurity and other things. So
what I do is I call the patient to set up the time for my community paramedic to go out. And we do some wild things. Like my community paramedic was one place, something was going on, and we had a patient who needed her portable toilet. So I went on ahead and put that sucker in the vehicle that we have and went on ahead and installed it. Those are things that we are doing. One of them called and she said, I can't wait till he comes. I said, tell me more. She said, he listens to me.
Yeah.
I was like, oh, I love that. I said, tell me some more about it. She said, I'm really going through some stuff. I really need to find another place. And so we went to a fair to get all these resources of like housing for the aging, what food banks are around so we can give them the number. So we're helping them collectively community-wide now. I think that it's changing quite a bit, but our community paramedic, he's such a personal dude,
Yeah.
He's so personal that I think it's innately for him to say, hey, let me go get you a glass of water in your house so we can sit down and talk. I see you're really thirsty, or what's going on? Oh, let me help you with just little stuff.
Yeah. Now, you mentioned geriatrics. Do you have geriatric emergency departments?
No.
Do you have the specialty? American College of Emergency Physicians has a great site on their geriatric ED. There's a lot of grant money, I think. I did a podcast with, it was ASAP, I think, and it's a geriatric podcast of some type. But we talked about this specialty rotation that we started, which unfortunately came to a halt right now because the geriatric nurse who is going to guide them is on leave.
Oh, okay.
Unfortunately, because it's a terrific rotation. We were really just starting to beef it up after the last two classes. This would be our third cohort going through it. And the focus follows the geriatric patient through the emergency department. One of the special areas is in discharge planning. So when they have discharge planning, they're getting ready to discharge the patient. This is where EMS comes in. You're the only ones, I keep saying this to students, you're the only ones who have been in that home, that when they're in the hospital, you're essentially, when you arrive in an ambulance at a hospital, you're arriving at an MCI. That's what a hospital emergency department is. It's an MCI. The person that greets you is called triage. So there's a hint that you're walking into an MCI. So it's super critical that you bring all of the information, the social, environmental, even if the patient's critical. When people say, oh, the patient was critical, I didn't have time. Yeah, you do. You have 9 people on your scenes half the time now. And even if you don't, someone has the wherewithal, especially once you get experienced in EMS, to be able to do the critical management and still know what kind of environment you came from, whether or not it was cold, whether it looked like there was power on anywhere, whether or not there was some social needs. You know that in a few minutes when you're on a scene, or someone will. The person who's standing back, looking around, taking the history, they can actually see quite a bit from that scene. What's the point of taking that person, critical patient, to the emergency department, resuscitating them, releasing them back to the environment that put them there to begin with, without intervening, and then complaining that you go back there all the time? That hello, that doesn't make any sense.
The intent is not having additional admissions within a 30-day cycle.
And the intent is to recognize that we actually are part of the problem. We're part of the problem if we know that we keep going back to this place and we just keep going back.
That's how we're using our community paramedic program to try to prevent that. Thank goodness. Everyone's program is different, though. Some are from the EMS side, some are from the hospital side, because we do attend the IDT meetings too.
Yeah. And then some are also based on different things. Some are based on, depending upon, like you said, the community assessment. Is it the readmission reduction that's needed in the area? Or in San Francisco, it's, homelessness, addiction, counseling, opiate crisis. It's a lot of, follow-up. We just had Suboxone instituted in the area. So we're just starting with that, and changing that mindset is really interesting too. Well, a lot of that comes with information, the right information, getting the physicians and the nurses and the paramedics, the leaders who know the accurate information about what is successful and what isn't in terms of treating opiate use disorder, to present the information and get in front of those rumors and all of that stuff that starts to propagate and perpetuate out there. You get them out there and constantly in front, and suddenly you start to see the mindset change about the use of Suboxone in the field. So we're just starting to do that too. So every community is different, right? Based upon their needs.
Yeah. Not many people understand that.
No, that's true. That's why I love your question on accreditation here, because people think of accreditation as cookie cutter. Well, you're creating cookie cutter programs, but not really. It shouldn't really do that. We do have a baseline standard. We know what CPR is supposed to look like. We don't just, say, well, we can make up in our area our own form of CPR, right? We have best practices and standards. And so there is always a floor, but then between that and the ceiling, that's different. That's where innovation comes in.
Yeah.
So
you're talking about clinical practice all the time, which is awesome, and how you're working with the students at your college, which I like. One of the questions I did have was, what drove you to challenge traditional approaches and norms in education and clinical practice, and how has this perspective shaped your role as a paramedic program director? And I think you spoke a little bit about that, though.
Yeah, I started full-time as program director in 2003. Oh, it was post 9/11, because I remember the student population was very different. So people were leaving tech, they were leaving office jobs, they were leaving finance, high-paying jobs for meaning, because they felt after 9/11 occurred, everybody wanted to do something, right? They wanted some meaning in their life. I think we're seeing a similar shift right now post-COVID, but it's different. It's very different. At that time, people just said, you know what? I'm done with this office job. I need to do something where I'm actually, helping people. And so we saw a flood of what now would be called inexperienced people coming into paramedic school. They went to EMT school and then into paramedic school because, first of all, the job market was completely flooded. They would come out of EMT school and not be able to get an IFT job at that time, which a lot of people can't even imagine right now.
Right.
But that occurred for many years. In the first 15 years I was a program director, it was a pretty flooded job market. So they were coming from tech. And then I was part-time before that, but I was working as a paramedic, and then I was at our local EMS agency. But the student feedback, the early and mostly direct, not surveys, when I first started full-time, and I started doing a lot of the traditional lecturing, here's the chapter stuff. I mean, you come in, it's like, here you go. There's your classroom. And so you're like, okay, I'll do what's easy. I've got these things that are here, and I'll just read through them until 1:00 in the morning and make sure I've got my organization right. And then we'll start. And very early on, like first week of class, I had an older student come up to me and say, that was 5 hours of talking. And I was like, not used to that at all. I knew I needed help. I needed to really start thinking about it. But what I was intimidated by is they handed me a class of 40 people from tech, and I was like, how do I do this? So I started worrying about this. I started taking all kinds of workshops through college. I took this one again in 2003. So online then was just brand new, called Active Learning Strategies for
Oh,
adult and
wow.
adolescent learners. And what I loved about it is every week you'd report and the instructor was there. And actually, it wasn't on camera, it was all just online. So we're typing back and forth, it's messaging back and forth, but you had groups. And our groups would come up with an exercise. Hey, I'm going to try Jeopardy this week. I'm going to try jigsaw learning. We'd pick something from this book and we'd try it. And then we go that week and try it in our class. Then
Oh,
we
wow.
come back and we talk about which worked and which didn't, and each one would have feedback. And I focused on how to do things with large groups because at that time I had very little help. And then I had to turn that into telling my college, I need more resources so that I can break people into groups. Then I remember very clearly taking a workshop that Dave Page was running. And I can't remember if it was through NEMC or what. It was a workshop though. And he and Heather Davis were talking about working in large groups and doing things like breaking groups up and rotating them into different rotations and monitoring those rotations. And I started doing that, and I started reading more on best educational practices. At that time, clickers were common in lectures. So there was clickers. Now there's 100 other things to get people engaged.
Kahoot's amazing too, yeah.
Yeah, so Kahoots and clickers and all of that kind of stuff, getting people really engaged. So I started to learn to do that, but I still saw if you have a large group like that, there's going to be some people you're losing. I'm not satisfied. I still am not satisfied with, well, there's always going to be some attrition or whatever. I'm never satisfied with that because people don't get that far without wanting to be there. So, it's not like they're just sampling. They really want to be there. If they've come through the EMT and the prerequisite and the application, I have to assume they want to be there. So each and every person deserves that attention. I've never been satisfied with, so many of them are going to be weeded out or whatever. I think that's baloney. That was kind of like, how do we get to everyone? It's still like the thing. Well, how do we get to everyone and how do we keep them there? I mean, if they choose personally, look, you know what? I have too much going on in my family right now. And you talk to them about that. I've had talks with students where they've said to me, there's so much going on right now. I don't know if I should stay in the program. And I've had discussions with them about, how sometimes your cohort can help and talk them into sticking around. Hey, census is not for a couple more weeks. You have time before you can drop and still get a full refund if you're paying for it. So talk to them about that. They might stick it out. And every so often you have a student that's like, I'm so glad I stuck it out because my cohort really helped me. I was starting to go through a divorce and a custody battle, and they really helped me emotionally, and having this time to spend on it helped me. And so they stuck it out and they stayed. And then I've had others where it just was too much. They had maybe a sick person they were taking care of, and then they return. Maybe they return 2 years later or a year later. The open door part of it, I think, is really important for them to know you don't have to finish. You don't have to do this now. It's okay. It's education, and you want to be present as much as possible.
Right.
So, but I think, when you said challenging norms in education, I think what has been a norm is a culture around the bell curve. There's going to be some that are going to do great. There's going to be some that are not going to do great. And that's a system we set up. It doesn't have to be that way. We can use mastery learning. We can use simulation-based mastery learning. We can use, competency-based learning so that everyone actually meets it, but they do it at a different pace. We don't have to do it where we say, here's the start, here's the stop.
Right.
It's more challenging because of the system we built. That's why it's challenging. We built the education system to run like this. Whether it's a college or an agency, we built it like that to say, this is what you have to meet. You have to meet it in this time, the end.
It's the honest truth. I speak to several educators, not as often as I once did, but when I do speak to them, many still feel it's just that still.
Yeah.
But it's not. It really isn't. And it lets you know who's willing to make additional progression. And I say that, not speaking ill of anybody, when you are taking the intent to learn other ways, that's part of your growth in education. I hope you enjoyed this episode of Cold Press Conversations. If you love this episode as much as I did, I need you to head on over and subscribe so you never miss an episode. This is Dr. Jewel signing off to health and cognitive happiness.